Good evening, everybody, and welcome to this week's BDA webinar. I'm Rebecca from the BDA events team, and we're delighted to have you with us tonight. During tonight's session, we will be exploring Ehlers-Danlos syndrome. Moving on to the speakers, I will just get them all up on screen with me. I'm delighted to be joined tonight by Audrey, Alan, and Linda. Hi, Audrey.
Hi.
Just get Alan and Linda up with us.
Hi, Linda.
Hello.
Great. Hi, Alan.
Hi.
Thanks for joining us.
Thank you very much, Rebecca, for that. And thank you, everybody, for your patience, and thanks, everybody, for coming along. Today, we're going to be talking about a much misunderstood and underdiagnosed condition. And we all want to show you how this is so relevant to every member of the dental team on a daily basis. So what is the problem? As Alan Hakim's colleague Rodney Graham once said, no other condition in the history of modern medicine has been as neglected in such a way as Ehlers-Danlos syndromes. Yep. So we want to open your eyes today to all of this. You've already seen the expected learning outcomes, so we'll just whiz through those. So to begin with, my name's Audrey Kershaw. I'm a GDC specialist in oral surgery, and I work peripatetically throughout Scotland. I did teach medicine and surgery at university for 15, 19 years or whatever, and I'm also an EDS allied clinician. We'll move on, and Alan, we're very delighted to have you here, Alan. Never did I think a podcast with you both. We're delighted to have you. Could you tell us a little bit about yourself, Alan?
Yes, of course, and thank you very much for the invitation. I'm Alan Hakim. I'm a consultant rheumatologist and an acute physician based in London. Over the years, I've done a lot of clinical practice in the NHS, management practice, all the way through to clinical commissioning. I've probably spent about 26 years in this field, and I've done a lot of clinical research, education, authorship, and I'm the Chief Medical and Scientific Officer at the Ehlers-Danlos Society.
Oh, thank you very much, Alan. We're so pleased to have you here. And we move on to Linda Bluestein again. Never did I think we could all do a podcast to Linda. It's just brilliant. Tell us something about yourself, Linda, and I'll fill in the blanks that you forget to tell us.
Sure. My name is Linda Bluestein, and I'm an anesthesiologist. I now practice integrative pain medicine for people with EDS and related conditions. And I got into this much later in the game. Dr. Hakim was so generous to help me in the early stages when I was trying to figure out what was going on, because I have hypermobile EDS myself. And I started the Bendy Bodies podcast as a way of sharing information with people all over the world so that information could be as accessible as possible.
Great. Linda has basically got 1 hour, 15-minute podcast on each of the slides that I'm doing today. So we'll try and give you a briefer version, but Linda's podcasts are absolutely brilliant, and go there and have a great look. So these are my 2 poodles. Before I got poodles, I never noticed poodles anywhere, but once you're made aware of something, you can't help but see it. Now, wherever I go, I see poodles everywhere. I'm not making them up. And they were always there, but I never saw them. And this has been the same with my experience of Ehlers-Danlos syndromes. So Alan, can you maybe tell us, what are we talking about today?
Yeah, absolutely. So we're going to be talking about the hypermobility syndromes. That's a very broad term for a particular collection of conditions that sit within the whole family of the hereditary or heritable disorders of connective tissue. Now, if you look up the heritable disorders of connective tissue, you'll find that there are over 200 different classes of them. Don't worry, we're not going to talk about all of those today. We're going to focus on what is the most common. That's the Ehlers-Danlos syndromes, of which there are 13 types that I'll break down in a little while, and hypermobility spectrum disorder, which is the most common of the hypermobility syndromes.
So that's great. So what are these, Alan?
Yeah, so in essence, we're talking about conditions where there is either a genetic abnormality of collagen structure or other structures that are related to collagen, other proteins, or there's some kind of collagen dysfunction as a consequence of what's going on in the extracellular matrix. The reason why they can be so profound and disturb so many parts of the body is because collagen as a protein is pretty much everywhere, in every building block of every tissue in one form or another. So depending on which types of collagen are affected, you'll see particular types of disorder as a direct consequence of these collagen or collagen-associated abnormalities. So every body system can be affected, and often it's actually not very clear, particularly at a young age and into young adulthood, that there's actually any problem at all, because outside of seemingly being a bit bendy, everything else appears to look normal, but the manifestations are really quite profound and diverse, and can cause considerable amounts of comorbidity over the years.
Well, that's great. So the different types of Ehlers-Danlos, Alan.
Yeah, so this is the slide that you're going to be tested on at the end of this webinar. No, not at all. This is a ghastly slide, but you'll see it absolutely everywhere in every paper that's ever published. And it's the 2017 classification of the 13 types of Ehlers-Danlos syndromes. You'll see that we put 13 plus on the previous slide, and that's because lo and behold, there are more genes being discovered that are describing different subtypes over the last few years. So you'll see down the left-hand side of the first column the different names in alphabetical order, more or less, for the various types, followed by, in the next column, whether they're autosomal dominant or autosomal recessive in terms of their genetic pattern of inheritance. And then for each of them, apart from the hypermobile type of EDS, there are several known gene variants that are pathogenic and cause these disorders. And the protein that's affected is described over on the far column on the right. So this is the distribution of the Ehlers-Danlos syndromes in their current classification, and they all have very specific types of abnormality to them that lead you to think that you may have one type rather than another clinically before you might do a genetic testing. We call those red flags, and we'll discuss some of those further on in this webinar. But the truth is that if we're suspicious, we do actually just run a gene panel, and the gene panels these days look for all of these genes rather than just choosing one gene, assuming that it's one particular diagnosis. So you've got a clinical pattern and a genetic pattern that helps you work out which of the types you have.
So Alan, that's all great, but a lot of people still even haven't heard of Ehlers-Danlos. I sent a patient to their doctor in Scotland the other week, and the patient came back to say to me the doctor had never heard of Ehlers-Danlos. So yeah. These can't be all that rare, can they?
Well, what tends to happen, certainly, I think, in teaching as an undergraduate, is if you hear about it at all, you'll probably hear about the classic variant of Ehlers-Danlos syndrome, the person with extremely stretchy skin who can do all sorts of contortion tricks and would look perfect in a Victorian circus. That is a very, very old-fashioned view of the totality of the Ehlers-Danlos syndromes. And yes, some of these types are extremely rare. They're called ultra rare, 1 in a million people. Some of them are rare, 1 in 10 to 50,000 people. But the hypermobile type of Ehlers-Danlos syndrome is much more common than was ever realized. Now, here we've listed just 3 papers that have described this, and there are more papers that have triangulated all of this together. But if you look at Sedelov's paper, which is a population within Sweden, we can see that the hypermobile variant of Ehlers-Danlos syndrome probably has a prevalence of around 1 in 3,000. It's the rarer types that take you up to 1 in 5,000 or less. Demner and colleagues actually looked at data from medical records in Wales, and there they identified that the prevalence of hypermobile EDS or the hypermobility spectrum disorder was around 1 in 500 to 1 in 800, so much, much more common than you would have thought. There are many poodles in our clinical practice that you have probably missed, and that's okay, but now you're going to spot them all. Now, if you then go to a piece of work that was done in the northeast of England just very recently, bearing in mind that this is a practice where a lot more awareness of EDS and HSD exists, they identified in their clinical practices that around 1 in 200 to 1 in 250 people had a hypermobile EDS or HSD diagnosis in their region. It is common.
That's great. So it's much more common than a lot of us ever thought. So let me tell you a little bit about my journey, okay? When I was a dental student, 1984 or so, when I started clinical to 2018, I knew there was something going on with certain cases, the ones that wouldn't go numb. I knew there was something I wasn't understanding. I never thought I would ever figure out what it was. On the 23rd of July 2018, I was chatting to a medical friend and I found out what it was. And that was a complete game changer for me. Move forward to 2024. I added up the figures because I keep a note of everybody I see because I'm in private practice. I see round about 12.8 of my cases have something that very, very strongly resembles a connective tissue disorder going on. So that makes it round about 1 in 8 of my patients that I see something. These cases, if we pick up, I have never been wrong. Now everywhere I go, I see poodles. This is not a mirror image. These were real. Yep. So when do I find the cases? I find them when I'm removing poorly formed first molar teeth for orthodontic extractions. The patients may be anxious. Wisdom tooth removal. When local anaesthetic has failed and they think, what can they do with this patient? Send it to Audrey. Bleeding sockets, bruising. Patients who have a lowered pain threshold, that sometimes flags it up to us. There's something going on. When patients are anxious, they get referred to me. When they've got TMD issues, they get referred to me, facial pain and halitosis like that. What I have to say is, because I'm a specialist in oral surgery, I don't see a representative sample of the population. I tend to only get the difficult cases referred to me, and that's fine. That's what I enjoy, and that's what I'm there for. So some patients that could walk into your clinic because you're thinking, okay, this is still doesn't really apply to me. My GDC CPD is due in the end of the month. I need to get some CPD points. I'll just stick this out. Some patients that could turn up to your clinic, Russell Kane. All of these people have got Ehlers Danlos or HSD. And don't they all look so healthy? Billie Eilish, Deliciously Ella, Sia, Jamil. Ella, when she was a student in St Andrews, which is just 8 or 10 miles from here, she took very ill, long time to diagnose. She has a very good write-up in the front of her book about her Ehlers-Danlos, her POTS and her mast cell issues, and Linda will go on and talk about those later. Jamil Allen, I think she speaks very openly about this. She was diagnosed by your colleague, Professor Graham. And Jamila says that as a 7 or 8 year old, she's actually in the papers that Professor Graham wrote. She's very open. She does absolutely amazing podcasts on Ehlers-Danlos if anybody wants to look into them. So there's many, many, many famous people with EDS, and it's really all out there. So when do I suspect? This is a little bit tongue-in-cheek, but this is how we do it on clinic. I now work with such supportive nurses and managers, and I work in 6 or 7 different places. The staff now often pick up cases before I do. I can pick up cases from a 3 or 4 line referral letter, and the nurses can now pick it up as well, and they give me a little bit of a nudge. So the things that make us suspect: patients look younger because of the difference in the collagen. They're anxious and they're sensitive, and we'll talk more about this later. Anxiety tends to be built in with these conditions. They tend to be overdressed for the weather because, as Linda will tell us later on, they can have dysautonomia. So they can be very cold. They can also be very hot. But this is how we recognize patients in our waiting rooms. They sometimes like very, very soft wools. Other times they'll say what some of us feel are very soft wools are far too itchy, but we can spot them. they maybe tend to keep moving, and they might sit with their arms crossed or their legs crossed in the waiting room. What these people are doing, and they don't know about it, is trying to keep their blood pressure up because of their POTS or their orthostatic intolerance. They can, if they smile at you, you can see the white spots in their teeth because their teeth can be poorly formed. With their blood pressure issues and whatever else, they can have a very cold handshake. That's another thing that alerts me to this. One practice I work in, we serve them coffee or whatever they want before they come in. A lot of patients with EDS, but not all, they have to avoid caffeine. So they ask for the decaf. They ask also for the soya milk, because some of them can't do cow's milk. They carry a large water bottle because they need to keep very well hydrated. Another thing, Linda and Alan, I'm really picking up on clinic now is in the past few months, I've just homed into it. When patients are sitting in the chair, it's their thumbs I see are bendy, and that gets us into the conversation. I don't have overly bendy thumbs, maybe you do, Linda, but you know, when you look down and you see them sitting with their hands crossed, and oh my goodness, look at those thumbs. So these are all things that you can look out for. And I know this is a little bit funny, but RAB jackets, if they want to sponsor me, please, RAB, do so. RAB jackets are made for thinner individuals for climbing, so the arms of the jackets tend to be longer. I know it's just a little bit of a joke, but the number of times we spot somebody coming in with a RAB jacket, it's really quite funny. So this is Emma, and I suspected Emma when I got a call from the practice the day before I saw her. It was just a call. The reception staff didn't know what I really did. They didn't really know what was going on, but they said, "We've told Emma she needs to see you, Audrey," because they seemed to think I did amazing things. And I'm so glad that they thought that. So we suspected Emma before she came in. Sorry, where's my mouse again? Yeah, she's a 32-year-old lady. Look at that amazing skin. Just look at that skin. She had TMD issues. She had a carious wisdom tooth. She was anxious and tearful, but the referral letter said she copes very well. And sometimes with EDS people, there's these two things going on at the same time that don't seem to make sense, but they do. She was hesitant to seek help. We also threw in a few medical issues in her referral letter. I don't often get medical issues like this in. I'm surprised Emma bothered to tell us about it because she had been dismissed by so many medics over all this. We were certain Emma had Ehlers Danlos, and what Emma said was a whole host of complicated health problems for 20 years. The doctors failed to diagnose her. She walked through our door. We instantly knew what was wrong with her. So emotional to finally sit in front of somebody who was listening and understanding and able to explain it all to her. She genuinely cannot thank her team enough. She feels so empowered to understand her health now, and that is a thing I find in almost everybody I find. They are so grateful for the knowledge, because knowledge is power. What we did for Emma, and I don't think I said in a previous slide, in 2024 I picked up 120 new cases. Yep, so last year we picked up 120 Emmas. What we did was absolutely amazing. It was absolutely great. It's not only me that can do this. We are here to get every single one of you on this podcast being able to pick up cases and get them help, because I've got my hairdresser now able to do this, and I've got an artist friend. Yep. And it's just great to be able to do this. So Emma drew me this look. It wasn't directed at me in particular. It was directed at every other healthcare professional she'd ever seen. And she said, "So do you mean to tell me I had to come to the dentist to be told this?" And a lot of them have a sense of humor, which is just great. And I said, "Yes, Emma, you did have to come to the dentist to be told this." Yep. And she was just absolutely delighted. So everybody in healthcare comes at this from different angles, and we all have chances to pick up cases. So here we have Alan is having a look at the knees there. Yep, and Alan's trying to figure out what's going on there. We have Tara Renton looking at those white tusk things, trying to figure out if they're teeth. I hope you're on the top tonight, Tara. We've got the GI surgeon trying to see what's up with the diarrhea and the whatever, doing the colonoscopies, dermatologists looking at the skin there. Everybody has got their chances to pick up EDS because, as Linda said, Alan said earlier on, there are so many signs and symptoms. There's no role for doctor bashing here. GPs have a hard time. They maybe have 10 minutes with a patient, and they were not taught this. Everybody's trying their very, very best, and we've all just got to try and spread the word on this. So this man was the first to talk about Ehlers-Danlos in 400 BC. Yep, Ehlers-Danlos is nothing new. Yep, it was spoken about way back then. When I was at dental school in 1982 to 1987, sorry, what's happened to my slides here? What's happened to my slides? This is what a poodle looked like when I was at dental school, and we now know these days. Linda, I don't think your poodle looks anything like this, and my children would disown me if my poodles looked like this. Yeah. So fast forward to today, the same with Ehlers-Danlos. Back when I was at dental school, and I still remember this when my friend Joy said to me, I think this could be Ehlers-Danlos, Audrey. It was blue sclera, stretchy skin and mobile joints. And if that didn't come into it, we weren't even going to think of Ehlers-Danlos. If we move forward, Linda, I think you'll maybe help us with this slide. We'll see that Ehlers-Danlos is so much more than those three things.
Sure, and that line that you had at the beginning, if you can't connect the issues, think connective tissues, is such a great, succinct way for all of us to think about this, because since connective tissue is present all throughout the body, it's one of those things where when you have a whole host of things on the review of systems, it's a really good thing to be thinking about. Could this be a connective tissue disorder that can actually tie all these things together? And I really like this graphic because it shows a lot of the different things that can be going on. There's a lot of others that are like this, but if you just think about all the different systems in the body pretty much can be affected, whether it's, you know, chronic pain, joint instability, gastrointestinal problems, fatigue, sleep disturbances. There's a whole host of things that can happen.
Yeah, I think you know our colleague Tara Renton, Linda. I think you did a podcast with her last week. What Tara Renton and I have said to each other is we have to get rid of this what is relevant in the medical history. You're only going to the dentist. You don't have to tell the dentist about your gut issues and your blood pressure issues and everything else. Everything in a medical history is relevant, and we need to start doing that. So Linda, yeah, if you can tell us a little bit about this as well.
Sure. So we talked about what the Ehlers-Danlos syndromes are, and the hypermobile type of Ehlers-Danlos is the most common. And just to back up a little bit on that too, hypermobility means that a joint or a group of joints has greater than expected range of motion. And then also the three core features of Ehlers-Danlos being the joint hypermobility, or it could be joint and or joint instability, stretchy tissues, which, as you said, is not necessarily, I think Dr. Hakim said, it doesn't have to be the crazy like classical EDS type stretchy skin, but you see changes in the skin, and then you see weak tissues. So those are the kind of the three core features of the Ehlers-Danlos syndromes, of which the hypermobile type is by far the most common type. It's also the only type that we don't have genetic testing for yet. So we're getting closer maybe to having a biomarker, but we don't have one yet. And we also know that hypermobile EDS occurs much more commonly with autonomic dysfunction. So one of the conditions of autonomic dysfunction is POTS, or postural orthostatic tachycardia syndrome. So when people go from laying down to sitting or standing up, they have to have symptoms for at least 3 months, and their heart rate has to go up by 30 beats per minute as an adult or 40 beats per minute as a child. They'll have difficulty with temperature regulation, gastrointestinal problems, a whole lot of the autonomic things that we don't think about. And then the other thing that occurs very commonly, we call this a triad, is mast cell activation or mast cell activation syndrome. And the mast cells are a part of the immune system, and they cause atrophic changes. They will cause inflammation and allergic type phenomena. So the tricky thing is, if you were to imagine like listing a bunch of symptoms for each one of these things, in that middle area, you're going to have some symptoms that could represent any of those conditions. So we don't totally know why these things coexist. We know some reasons. For example, something called hereditary alpha tryptosemia can cause a picture that looks like all of this. But these things are just things that we should always be thinking of because they commonly occur together.
That's great. And we quite often see neurodivergence, say, yep.
Yes, yes. Not lately, but up until recently, those were the most popular episodes of my podcast, were the ones with Dr. Jessica Ehlers, because this is a really, really hot topic. People who have neurodivergency, whether it's autism, ADHD, et cetera, it could be dyslexia, dyscalculia, there's a whole host of them, but they appear to be much more common with people who have one of the Ehlers-Danlos syndromes, and especially hypermobile EDS. So that's just another important thing to be aware of when we see that we should be really, keeping our eyes out for these connective tissue disorders.
Yeah, that's great. We'll just miss it. So I was going to miss this slide out, but sometimes patients with EDS, HSD, they have got something as well called sensory perception sensitivity. And I'm not really too sure, I'm not sure if people really know how that maybe ties in with the neurodivergencies, but it's that friend that knows everything. They walk into a room, they know what's going on, they get all your stories out of you just by looking at you. And I know a few of us sort of joke at it that we would have been considered to be witches and we would have been burned in the stake in years gone by, but we would have had company, yeah? So Linda, what you were saying before was people with EDS, HSD, they can present in many, many different ways. And I think this is a really nice way to show it. If you know one person with EDS, all you know is one person with EDS. And, somebody could have a lot of joint issues, another could maybe not have a lot of joint issues, other have a lot of GI, whatever, yeah? So I think this is a nice way to see one person compared to the second person. You've also got to realize that one person can be this way one year, they can be another way next year. So that's just really important to keep in mind. So sometimes it's difficult to tell what we're looking at. There's one poodle there and there's one bowl of porridge over on the other side. A friend sent me that. So the biggest communication problem is we do not listen to understand, we listen to reply. And I think the EDS patients that I see very much say this. And this is one of the big reasons why they don't get the diagnosis early on. So we have to start listening to our patients. So Alan, you could maybe tell us a little bit about acute issues. I know you and I have spoken about this a couple of years ago.
Yeah, absolutely. So most of the things that we've described so far may be clinically important things in the history to pick up the diagnosis. They may be important signs. But often they become chronic conditions amongst the comorbidities. There are some acute situations that might make you think of what we call the red flags, and this would make you think there's something, although there may be EDS present, there's something perhaps more akin to one of the rarer types of one of the genetic variants. So very serious bleeding, although many of our patients with hypermobile EDS will describe a profound tendency towards bruising, maybe slower healing from a cut wound. What you're looking for is a history of really severe bleeding that may have come from trauma, from surgery, postpartum, and also very large hematomas. This would make you think that there may be a vasculopathy. This would be a red flag that would require you to think about genetic testing. Take that further into the larger blood vessels, aortic dissections, aortic rupture, cardiovalve disorders. You're now in the territory of red flags and rarer types of EDS. Pneumothorax is also in there, bowel and uterine rupture. And really interesting amongst the acute issues, and one that we don't fully understand, the research has shown that suicidal behavior, whether it be suicidal ideation or actual suicide, is higher in our community. There are lots of reasons why that could possibly be. They haven't been fully elucidated, but if one thinks about the extent of the pathophysiology, the complications of the disease, and the lack of understanding and the lack of support, maybe something sitting in there that's way above and beyond anxiety and depression.
Yeah, thanks, Alan, for that. I very much come at this from a different angle than you, Alan, because I'm just a dentist out in practice, seeing routine people walk in the street. And it's quite interesting because, for example, collapsed lungs, I have never had a patient come in saying they've had a collapsed lung that doesn't then show very strong signs and symptoms of Ehlers Danlos. So this takes us back again to all the medical history is so relevant. And, you know, it's also just important, we want to try and get these patients numbed up. It's more difficult to get these numbed up. So if we see that in the medical history, before we go down the great big road of getting them diagnosed, it's just a nice little reminder. Let's be careful we get them numbed up.
Major clues, absolutely major clues. So I think the important thing is that this is the territory of all of the more complex heritable disorders of connective tissue. Because you could have an aortic problem and a pneumothorax with Marfan syndrome, which is probably far better recognized as a syndrome amongst everybody than the Ehlers-Danlos syndromes. So what it's telling you is that the history is flashing, you know, bright white lights at you saying, I have some kind of connective tissue disorder. Please listen to my history.
Yes, that's great. So, Alan, as we've heard said so often, and you've just got to laugh because you would cry, there's no point in knowing as there's nothing that can be done about this, Alan.
Yeah, okay. So this is something that we hear time and time again. And I will say that I hear it from some of the most eminent people, and it's really depressing and disappointing. And actually risks, I would say, these days with the information that we have, placing somebody in a very vulnerable position as a clinician if this is their point of view, and they did nothing for the patient in front of them. It absolutely is not true that there is nothing that can be done. There are so many things in the general toolbox that we have that can be done for all of the issues that we're talking about. And there are very specific treatments that have come to the fore through phase 2 and phase 3 clinical trials for people with vasculopathies. We have to make the diagnosis. We have to work out the nature of all of the comorbidities and their complications, and we have to treat those. It is, I think it's our responsibility to do so. And moving forward, I'm very much going to be of the opinion that anybody who says, I don't need to do anything about this, you can go away, is likely to find themselves in trouble because that just simply isn't true. However, because this is an experience for many of our patients, the average delay to diagnosis, because people aren't listening and thinking about the condition, is 10 to 12 years. So a lot of people will actually come with a whole load of baggage, shall we say, related to their need for assessment and treatment. They've been disbelieved, there's mistrust of the medical system, there's often quite a lot of psychological harm, including PTSD. They've often had unnecessary appointments, multiple investigations, treatments that weren't appropriate because the diagnosis has been missed, or maybe treatments that were not appropriate because the hypermobility and the joint instability was missed. I mean, not only is this bad for the patients, but it's also bad for the NHS, it's bad for health economics, it's bad for families, it's bad for work. It's just bad. We all have to be able to do better. And we are working tirelessly to get that average delay to diagnosis down, and working tirelessly to get everybody to realize that in this big puzzle, there are pieces that you can deal with because you do have the expertise and you do have the toolbox to deal with them.
Mm-hmm. Yeah. What I feel about the figure 10 to 12 years, Alan, is these are only the cases that have now been picked up. Yeah. And from what I see on clinic and in my day-to-day life, I feel that figure is much, much higher. For example, I've got an 83-year-old patient she's now 87, and we're still trying to get a diagnosis. Now, she could probably have been picked up before she reached her teens. So I think these are only the ones that have been picked up. But even although 12 years is still far too long.
Yeah, no, you're absolutely right. There are a number of people in our aging population who have never had the correct diagnosis. and are suffering quite considerable consequences of long-term delays in treatment.
So Linda, you are tirelessly working. You are doing an amazing job, tirelessly working with your podcasts and your website. We can't say about everything you're doing at the moment because we don't have enough time. But this is one bit of your website, or whatever we want to call it. Can you tell us a little bit about your approach to trying to help people?
Sure. Well, it started with helping myself feel better. And I was trying to think of an acronym that I could use to describe the different components that I used in order to improve my own physical health. I'm way better now at age 60 than I was in my 40s. Way, way better physically, emotionally, etc. And so these are just the components of the treatment plan that I basically did for myself and that I use on my patients. And when I see them back in follow-up, I kind of think through the different sections and I think, okay, is there something that we're missing in terms of, modalities? Is there some modality that we can add, et cetera? And I do have a paper that I wrote about this called Hope for Hypermobility. And this was in part 2 of that CME series for pain management.
That's great. So we probably don't have enough time to go through all of these, but Linda's paper is wonderful, yeah? So Alan, tell us, how do we get a diagnosis?
Yeah, well, so first of all, from our own learning, there's loads of information that's available on the Ehlers Danlos Society's website, so I really encourage you to look there. I can't claim that I have a conflict of interest because I also wrote a lot of the information on the HMSA's website in the UK, and I also support colleagues at Ehlers Danlos UK. So any of those websites, tons of information on how to assess joints, how to look for all of the other tissues that we've been talking about for their signs and symptoms, and how to make that fit together. You can join the ECHO program, which is a fully fledged education program that takes people through everything that they need to know. They have an opportunity to network with other clinicians, talk about cases. We run events, we have multiple webinars, and we also have our own healthcare professional directory, which you can link into and work with colleagues. So there's tons of opportunity for learning, for kind of increasing confidence and knowledge, and for networking, and it's the networking that I think is really key. When you're in the room though, and you've got all of those features that Audrey was alluding to, and a strange history going on that sounds like we're connecting the dots, and you want to just test, am I in the right territory? Then the Bateman score for generalized joint hypermobility is a very straightforward, quick test. It's made up of 9 points, and they're demonstrated here. 1 point is for you putting your hands flat on the floor. The other 8 points are made up of movements at the elbow, the little finger, thumb, and the knee. But you can also use the 5-point questionnaire, which myself and Professor Rodney Graham designed many, many years ago, and it still stood the test of time. It's a simple questionnaire. Any 2 of those affirmative will give you pretty much an 85 to 90% likelihood that the person in front of you has got generalized joint hypermobility, and that's your first clue. The way to then look at this, if you want to go to the next slide, outside the hypermobility, is perhaps just to have a look at the international classification for hypermobile EDS, and you've got the document here, and this is available on the Ehlers Danlos Society's website. You can see the criteria 1 is the joint hypermobility assessment. The criteria 2 picks up multiple areas that are looking at the skin, looking at the dental side of things, looking at the body habitus with the long arms, thinking about a number of different features that we've been discussing already, family history, a distribution of pain. So this, as well as being an aid memoir for the diagnosis, is also an aid memoir for thinking about the kinds of things you might ask individuals when you're trying to establish a diagnosis. Next slide, please. So that particular diagnostic workup was for adults, but in 2023, the Pediatric Working Group of the International Consortium on EDS and HSD produced this framework for the pediatric diagnosis of joint hypermobility. I'd encourage you to have a look at the framework, but it's still exactly the same concept. One is looking for the presence of hypermobility, joint instability, musculoskeletal dysfunction as a consequence, skin pathology, and then multi-system disease.
Alan, I've heard you talk about before that if people are not bendy enough, they don't get let into the party.
Yeah,
I definitely see this in my oral surgery patients, because as I said, I'm coming at a different angle than you from this. But if you're not bendy, so want to just tell us a little bit about that?
Yeah, no, absolutely. But first of all, just before then, what makes hypermobility spectrum disorder different from hypermobile Ehlers-Danlos syndrome is that if you've got the hypermobility and you've got the musculoskeletal problems, and maybe you have some of the comorbidities like POTS and mast cell, but you don't completely fulfill the criteria for EDS, then you're most likely to have the diagnosis of hypermobility spectrum disorder. Now, this issue about not being bendy enough, it may be that you've got bendy joints outside of the Baden score. We have been exploring this. I can't give you the information yet because it's going to be published at the back end of next year, but there are a number of other joints that could be looked at. And so the first thing I would encourage you to do, if you're still suspicious, is to look at some other joints and think, are these potentially hypermobile? But also, don't just rely on the joints. If the story is saying stretchy skin, is saying those acute red flags, etc., then you could still be in that territory, and that person either has lost some of their joint hypermobility over time, they may have injured their joints, and so you can't quite work out the hypermobility. The absence of the joint hypermobility does not exclude the diagnosis.
So Alan, when I'm on clinic, I sometimes catch myself halfway through a consultation and laugh and think, oh my goodness, I haven't even considered how flexible the joints are here, because I've got so many other signs and symptoms that I am sure even before I go towards the joints. And quite often the joints are not they're not fulfilling the criteria. I think another interesting thing is last year I picked up 120 cases, only 3 of them were men. So it's much harder to pick up men than it is women. And we don't have enough time to talk about everything today, so we'll pass back over to Linda and we can take questions at the end. So Linda, could you tell us a little bit about the complicating factors? Thanks.
I will really quickly, but I want to say two quick things. One, the 5-point questionnaire for me is huge. I love that. I ask every single patient gets that before I even see them, so I have that information. And also, I also want to point out that you can have generalized joint hypermobility without symptoms. So I feel like sometimes we lose that in the shuffle of all these other things. So when someone's young, we don't really know, are they going to develop symptoms? But if they're older, like I have friends now who are, in their 60s who are definitely have hypermobile joints. In fact, they probably even have generalized joint hypermobility, but they're fine. They don't have pain, they don't have other weak tissues, etc. Okay, so really quick to this slide. Yes, we know for sure that people who have EDS are more likely to get long COVID. Long COVID also often uncovers EDS type symptoms. So that's something that's really, really important to be aware of. We also know that puberty, generally speaking, helps males. The testosterone tends to help them build more muscle. So their symptoms in general often will get better, but females, that's often when the wheels fall off the bus, and that's when they start to run into a lot of problems. And perimenopause, et cetera, can cause problems. There's huge rates of central sensitization in these patients, so they often are diagnosed with fibromyalgia. And we also know that things like trauma, car accidents, psychological trauma also can be really, really exacerbating someone's symptoms.
So we'll just very quickly move on to the dental and oral issues here. That guy probably needs his teeth scaled. So patients are anxious. We've said that before. Changing collagen affects the brain and everything. Yep, the patients can be anxious. It is built into them. They're not just being silly. And I think it helps a lot of patients who we discover that they could have EDS to say, you're not just being silly. This is the way you are. And it's actually a great early warning system you have. We probably don't want too many people in one room at the same time who are just so anxious, but they are valuable members of the team because of this, got this really great early warning system. I also pick them up because they bruise easily, they bleed easily, they've got fragile tissues in their mouth. They have their TMD issues, they have facial pain. I know you've got the talk from Tara Renton coming out maybe next week on that as well. They can have a high arched palate, a narrow palate, muscle tiredness, or maybe difficult to keep their mouth open. They can have poorly formed teeth, and they can also have missing teeth. And that again is a way I very often pick up teeth when I'm sent a referral letter. Would I take some teeth out for orthodontics? I think they're missing some premolar teeth already. Yep. They can have pulp stones, taurodism. They can be very sensitive. So they're very sensitive psychologically and physically. So the sensitivity can be like, they don't like the taste of the local when we put it, get them a mouthwash. They don't like the colour of the filling. They can see the difference in the shade when we can't. And sometimes when I'm numbing somebody up, when I'm putting, I think they're writhing around in the chair. I'm thinking, have I lost my touch? But it's no, they're Ehlers, Danlos, and they feel things so much easier than other people. Going on to, and they also have associated medical issues that we have to take into account. They have difficulty going numb. Now, this was a complete eye-opener to me. This is a question that I've added to my history when I see every single patient. And I don't just ask them once, I ask them 3 times, because we've even had medical students and doctors not understand what it is to go numb properly. So I ask first, do you go numb at the dentist? Oh, yes. The dentist says I'm numb. I'm not interested what your dentist says, whether you're numb. How does your dentist know if you're numb? Sorry, my brain is gone on this one now. They feel that it's normal to feel pain when they're numb. They think their lip is numb. That was all we wanted, but they still feel pain in the tooth and they think this is normal. Well, no, this is not normal. That's not the point of local anesthetic, to freeze your big toe when you're having your tooth done. So I ask them in 3 different ways. Yep. Do they go numb at the dentist? One question I think is quite good, because younger people these days don't have as much dental work. So when they come to see me to have their wisdom teeth out, this is the first thing they're having done. So one of the questions I ask them is, have you had a contraceptive rod put in your arm? And that is the time when young girls might have had local anesthetic. And I will say to them, how was it? And very often, in the right people, they'll say, it was excruciating, and they didn't believe me. Yep. I actually had a GP, I managed to open a GP's eyes. She's good. Oh, really? That is why they won't go numb. Yeah. And as I said, I've had a medical student and a doctor not understand what it is to have local anesthetic work. Linda, you gave an absolutely brilliant thing on social media. You gave a 2-minute clip that I put a comment on. Can you tell us what you said the other day about how much you've learned about patients and local anesthetic?
Sure. As an anesthesiologist, I thought local anesthetics always worked, and I didn't understand that there were nuances to the impacts of local anesthetics. And so, you know, it's very important to be aware of this difference, because there are nearly 3 times, the studies show nearly 3 times the rate of local anesthetics, you know, not working versus people that don't have EDS. And there could be a variety of different causes for this, including, you know, because of the abnormalities of the connective tissue. It could be related to mast cell activation and inflammation. Could be related to the chronic pain, anxiety, and central sensitization that people have. Could be differences in drug metabolism and variability among the local anesthetics themselves. And I think you have a slide that shows that articaine is the most effective amongst the local anesthetics. So definitely asking, like you exactly just said, asking about their history is very important. How have you responded to local anesthesia in the past? And making sure that, yes, you can think of some ways, like what you just said about the implant in the arm, thinking of some ways that you can really elicit that history and get that information.
Yeah. So this was a paper, this guy, Hakim, he's been on that paper as well, I think, yeah? He gets around. So this was a paper that you wrote, Alan. It's a self-reported study. It's a great paper. It's the best we've got at the moment, but I think we're needing so much more.
No, we do, and it was, well, so the first work on this was reported in the late 1990s. I like to think that it was myself, Rodney Graham, and Colin Hopper, who many of you may well know, from Eastman Dental that wrote a paper in 2003 that really kind of brought to the fore that this is yet another issue for our patients.
Yeah, and it's a big thing for our dental patients, isn't it? So big. And I think as dentists, we're in a great position to be able to pick them up because this is such a big thing, Alan, as you said. And Linda, you've already done these slides for us here. We don't quite know why local anaesthetic doesn't work. I would say for some people it might work quicker, for other people it might work slower, for some people it lasts longer, for other people it wears off sooner. I think that would probably be quite right. Yeah, I know there's lots of questions coming in about what can we do about the local, but we don't have a lot of answers at the moment. So Linda, you did a podcast with Dr. Tara Renton last week, and you said that's maybe going out next week. And I think you're going to touch on a lot of these subjects. Almost every TMD patient I see has an undiagnosed connective tissue disorder. I see the TM joints when other people have tried to manage them for 18 months, but almost every single one, I know if they're booked on my clinic, it's going to likely be a connective tissue disorder. Migraines, sleep apnea. Listen to the Bendy Bodies podcast in a week's time. So what do I do when I suspect we have a connective tissue disorder going on? I have made an EDS meds questionnaire. It would be great to get you guys to look over it sometime, but it just, a lot of the questions, similar to what you've got, Linda, but I've added a lot of dentally relevant ones in there as well. We do a long medical history. We say, have you considered that your seemingly unconnected signs and symptoms could be connected? We remember a differential. Most people have been looking for answers, and almost everyone has just been delighted when I've said something. Then I email them a link to things. Bendy Bodies is high up there on the references. We have a standard letter we can send to their GP and specialists to say we've seen them. We can share all this with you. Refer on if we can. But as we know in Alan, we have nobody to refer to in Scotland. Yes, I have a osteopath colleague, Janet Gravener. Sorry, Janet, if I said your name there. I know we like to keep you hidden for my own personal use for my patients. Janet's snowed out. It's very, very hard to get help. Direct them to the Bendy Bodies, and we deal with the reason they've come. I ask the dental team, and I'm asking you guys here tonight, look for cold hands when you shake your patient's hand. If you see somebody looking younger, I was going to say earlier on, Linda, I think you said that you are 60. If you see somebody like Linda who tries to tell you that they look like they're 60, you need to be on to her. They look younger, they're anxious in the waiting room, and they've got bendy thumbs. Yep, look for that, because if you've got that, we're halfway there. See, all the medical history is relevant. Ask about local issues and easy bruising. See the case holistically, and that's a big word we've not used this evening so far. Case must be seen holistically. Alan, your echo course, which I went on a few years ago, absolutely brilliant. I think we're thinking of a specific dental one, Alan, and you've asked me to be involved. If we can, that would be brilliant. Anybody that wants to come on that, email us. Yep. We have a pack to aid finding these cases on clinic. I can share all this with you as well. So in summary, these conditions are poorly known about and understood, and the incidence is much greater than we thought. We need to be able to identify the signs and symptoms, even if just to know they're going to be anxious, local's not going to work, whatever, and then get them on for help. Many considerations for treatment. We've only managed to skirt over this. Go on Alan's echo course and you'll find it all, yeah? Every patient with EDS is different, and it changes throughout life, and the dental team has a huge role to play. What we're trying to do now is to get knowledge to as many as possible. When I started doing this, Alan, maybe about, I don't know, 4 years ago, I started my podcast. I had no idea we'd be able to reach as many, and with your help as well, Linda, I think we've now got about 9,000 or 10,000 healthcare professionals listen to my podcasts. We also did a very good jazz protrusive podcast, and that was a great one as well. So get knowledge to as many as we can, get it in the medical and dental school curricula. Alan, I just keep, when I meet somebody out dog walking from 9 miles or whatever, they're getting an email from me afterwards. Yeah, we will get there. We need an assessment tool for dentists. We've got my EDS pack. We need care pathways throughout the UK governments. My dogs have been helping in that. We had the PA to one of the MSPs. We're trying to get there in the 4 places. We're trying to get it spread. Linda, you spoke to Tara, who was one of the ones that wrote the TMD guidelines, the Royal College of Guidelines, and there's nothing mentioned in that about EDS, but I think Tara is on our side. We're trying to just let everybody know, yep, research and publications. Yep. If you need help, because I find 1 in 8 of my patients with EDS or HSD, I find it hard to go out for a dog walk without one finding me and the poodles. There were, I think, 250 signed up for this talk. There will be some of you who maybe think, oh my goodness, I think I've got this. Speak to us. You can contact me. I'm the only one that checks this email. This is Linda's website. I know Alan is there as well. EDS support helpline. They're open Tuesdays and Fridays, I think, and the HMSA helpline. References, as Alan said, EDS Society, Support UK, HMSA. This is a great paper by Chuck Norris with loads of references in it. Linda, you and I have done 2 Bendy Body podcasts. Linda, can I just say, I'm glad I saw you drinking a glass of water there this evening. I'm impressed. I am impressed. If you want to know why, you just have a look at the podcast, guys. Alan, this is a podcast you did with Linda and us, yeah? So that was a whirlwind through it. Thank you so much for listening. I'm so grateful, Alan and Linda, for you joining me, because that was so much better with you than without you. And if you have any questions, we'd be delighted to take them.
Guys, that was great, thank you. And we've had so many questions. Let me just get the folders up on the screen, and loads of questions. And you're right, there are a couple of people who suspect that they might have EDS, or that their daughter might have EDS. And I think Audrey shared her email address, and I have said I will pass their messages directly on to you guys to see if there's anything we can do. But yeah, loads of questions. So thank you so much. As Audrey mentioned, we have had a lot of questions about local anaesthetic, about it not being as effective as it is. I think the sort of questions, it's just people are asking, is there anything that they can do, like sort of what starting dose should they be looking at, any injection techniques? I think that's an area that everyone's quite keen on.
Could I answer that one, because we didn't have a chance to touch on this? I work in private practice. I am so lucky with who I work with. I'm so lucky with the team. Local anaesthetic working starts from the minute their dentist says, we need to send you to Audrey. Their stress levels reduce, their mast cells behave so much better. We need to reduce their stress levels, and Linda will know so much more about this than I do. They need to be happy to come, they need to be relaxed. We don't need their mast cells firing off, because that can be a reason why the local doesn't work. I quite often will phone the patient myself and just to say, we're looking forward to meeting you. I know you're anxious, but I understand you. Yeah. They're greeted very nicely at reception. It's the whole journey is important. Then we start giving the drugs. Okay. There's other funny things that happen. Like we had one patient, Birdie, who lets me talk about her. Oh, she was the most EDS person I've ever seen. Local didn't work. As we were taking out her wisdom tooth, she hummed tunes, and myself and my assistant had to guess what songs she was humming. I didn't have a clue what she was doing, but Linda, humming resets your nervous system. So, you know, a lot of the time patients know what they have to do. We could do a full talk on local anaesthetic, and I wonder if we should set that up on another forum. You saw from the paper what solutions work better than others. You know, we have to just work through, and I think Tara maybe touches on that in your talk as well. Linda, although I wasn't there, I think she touches on that. So we have to try different solutions in different ways. But to me, somebody once asked my nurse, how do you and Audrey get these patients numbed? And we just looked at each other and it was like, duh. And it's like, we don't know, but we almost always get them numb. And I think it is the simple things, just being nice to them. We also...
Linda, can I just ask you, so outside of dentistry, where we're trying to get things numb, say for biopsies, or
yes.
I wonder whether a general rule of thumb is, so it's a standard dose of lidocaine typically, standard period of time that you would assess to see if it's numb, and as you say, it has to be, does the person tell you it's numb rather than you have assumed it's numb? And if it isn't, to repeat that dose at least once and see whether 2 doses actually gives you at least a reasonable effect, or maybe even a full effect. That I've found as a general rule of thumb is a good starting point. And the other thing is there's actually, I understand that there is logical reasons why articaine may be better than the others. And that is that it's a much heavier molecular weight, so it maybe sits around for longer, and it's also much more lipophilic than the other agents, and so therefore gets into the tissues quicker. Now, I don't know whether these are just hypotheses, but it does seem to me that articaine and possibly 2 standard doses of the injection over a reasonable period of time is not a bad way to sort of start that process to see if you can get the anesthesia.
No, thank you for getting a bit of science back in this, but I will bring it down a notch again, Alan. The other thing that sometimes happens on my clinic is we have the manager coming in because she thinks that something's wrong. We do a lot of laughing. We do a lot of laughing on our clinic, and I encourage our patients to cry. I will say, we're not giving you the box of tissues, we're getting the kitchen roll out, and you are going to cry your eyes out, and we're here for you because that resets their autonomic nervous system.
Oh, completely. But I think so. With that in mind, it's almost potentially the wrong thing to do to be worried or anxious yourself if the local anaesthetic doesn't appear to be working for your client, because that may well actually set the wrong environment and make it even harder to manage.
Yeah. No, thank you.
Yeah, and I just want to add in there, because the procedure that I've done the most is epidural steroid injections, for example, or placing epidural catheters for labor and delivery. And there's a huge difference in how people would dose that, actually, even though like there is standard dosing, but there's still a range. So again, when I was practicing as an anesthesiologist, I didn't know these things that I know now, but I do know that sometimes I would go to do an epidural and somebody would be so scared because they would say, well, last time it was horrible. The procedure itself was horribly painful. And I believe that there are people who they'll infiltrate the skin and the subcutaneous tissues, and then they immediately put the needle in. And I would do that, and then I would wait. Now, I wouldn't wait 10 minutes, but I would wait a couple of minutes to let it set up. So, I think those just very, very small things that you can do can make a really big difference.
And I think I would just say one more thing around trauma, psychological trauma. If you are doing this and you find that the local anaesthetic isn't working because the patient is telling you, believe the patient. Carry on, because to put them through that trauma when it really isn't working is a terrible experience, and one that's very difficult to unravel at a later date.
And someone was also asking if there are any issues with trying conscious sedation with these types of patients, whether that's an option.
I can make one comment about nitrous oxide. So if people have MTHFR variants, which there is some data to suggest that, although these are very common in the general population, that they might actually be more common in people who have joint hypermobility and symptomatic joint hypermobility. If they do have an MTHFR variant, we do need to be more cautious with nitrous oxide because it can inactivate vitamin B12, and that's essential for methylation. So it's something that's quite common in the general population, but if a lot of people do know their MTHFR status, and especially if they're homozygous, you might want to ask them what their experience has been with nitrous oxide in the past, if that's one of the drugs that you're considering for sedation.
Yes, so I think when we're talking of IV sedation here, it's benzodiazepines. I have done quite a bit of sedation. I have done it on some patients that I've given the maximum dose, more than the maximum dose, and it's not working. These are all things, Rebecca, that we need so much more research into, so much more research. Some people with any drugs with EDS, you give them a quarter of the dose and it's like you've given them double the dose. Other drugs, you give them 3 times the dose, nothing has happened. We need so much more research, but before we can get research, we need doctors to be aware of what's actually happening, dentists and doctors. I mean, Linda, you have been so honest to say you didn't even think that it was a thing, that local wouldn't work. Yep. And if we don't believe it, if we believe it doesn't work, where are we going to get any research? Mm-hmm. Yep. So we need so much more research, Rebecca, to help these people.
Yeah, and I think having sat and listened to the talk, I can see you're starting to make the steps, but yeah, there's a long journey ahead. Have had a couple of questions, one from an orthodontist and one from a periodontist. So I'm going to cover those two off before we close up for the evening. So the first question, this person said, I'm an orthodontist and I've come across a few EDS patients. Are there any precautions I need to take when treating EDS patients with tooth movement?
I'm not an orthodontist, and we really need a specialist orthodontist here. I've still not come across an orthodontist who really understands EDS to the extent that I do. There is research to say that the teeth will move faster and it'll be much, much sorer. So I would say if that's the case, we need to use lesser forces. Yep. Because if we move teeth fast, we're going to damage them. But I'm not an orthodontist, but that's just gone back in my, so I think we would need to use lesser forces. I actually spoke to a colleague the other day and she said, oh yeah, this patient with EDS, her teeth are just moving like wildfire, yeah. So I would say you would use lesser forces.
Okay, and one last.
And also appreciate that it may be so sore. Until I saw my first EDS patient with braces, I didn't understand how sore braces could be. They literally could not put their teeth together for 3 or 4 days. They lived on orange juice. And it's like, oh, come on, you're putting it on. No, this pain is real. And the same as you, Linda, I mean, this wasn't a field that I worked in, but oh my goodness, I understood it when I saw it happen, once I had my eyes open. So thanks, Rebecca.
Two other things that come to mind from histories from individuals. One is there's usually considerable overcrowding. So trying to realign things in an overcrowded mouth, often in a small mouth, is extremely challenging. And secondly, things slip back into their poor, incorrect place as soon as you take the braces or any other treatments out. So follow up sooner than you might think for the general population may be valuable, just to check that the work that you've done has been maintained.
Okay, thank you. So last one quick question, I think we'll go with this. So someone's just asking, do you find higher rates of periodontal disease in these types of patients? And do they respond worse to the treatment?
There is a type of Ehlers-Danlos, periodontal Ehlers-Danlos. It is 1 in 1 million. I thought I had found a case last year, but we've tested it and it's not. You get worse periodontal disease in those patients, but in the other types of Ehlers-Danlos, definitely in hypermobile Ehlers-Danlos, you do not get worse perio disease. Okay. And there, our colleagues, Alan, the girls in Austria, Ines and Ulrika, they have got wonderful podcasts on YouTube. If you Google them, you'll find them. If anybody wants, I can send you the links. They have got really good half-hour talks on YouTube that explains about EDS, and they just seem really lovely, lovely girls who know what they're on about, and they're humble and they admit what they didn't know before and what they know now. So yeah, the gums may bleed easier in hypermobile EDS because the tissues are more fragile, but again, it should be seen as an early warning system. If you have your plaque and your oral hygiene sorted, you should be fine.
Yeah, and this is very much one of the red flags we were talking about. So if somebody comes in and you think that they've got a form of EDS, but actually they've had terrible decay from a very early years, and you think there's lots of pulp disease, you possibly have somebody with periodontal EDS in front of you.
Okay, I think that is all we have time for this evening. Audrey, Linda, Alan, thank you so much. It was a great webinar. It was really interesting to listen to. We're inundated with questions, and like you said, people were already starting to see it in themselves, in family members, in patients. So I think you've done a really great job starting to open people's eyes to it. So that just leaves me to say a big thank you again to everyone at home for listening, for all your questions, and to you three speakers. You were great. Thank you so much, everyone, for your time.